Hi, I'm Victoria.
And I'm Margaret.
And for our cranial nerve study tool, we did a poster because we are really visual, and this kind of helped us find pictures that were relatable. And then we also color coded each cranial nerve. So the reds are sensory cranial nerves, the blue are motor, and then purple is motor and sensory because red and blue make purple. So that was kind of a visual way for us to kind of learn that information. So next we're going to jump into functions. So for olfactory, its function is smell.
Second cranial nerve is optic, and its function is visual acuity, pupillary reflexes, awareness of light and dark, and orientation of the head and eye movements.
Cranial nerve number 3 is ocular motor, and this is extraocular eye movements up, down, medially, laterally, and downward deviation of your eyes.
Cranial nerve number 4 is trochlear, and its function is extraocular eye movements and downward and lateral eyeball movements.
Next we have trigeminal, and this is both sensory and motor, so its sensory function, it mediates sensation of the face, head, cornea of the eye, and inner oral cavity. The motor function, it innervates the jaw muscles that control your chewing.
Next is abducens, and its function is extraocular eye movements and ability of the eye to look laterally.
Next we have facial, and this too is a sensory and motor cranial nerve. So the sensory innervates the taste receptors on the anterior tongue, as is shown in this picture, and the motor is facial expressions, eyelid closing, and the stapedius muscle.
Next is the vestibular cochlear. The auditory branch transmits sensory impulses that are from vibrations of the fluid in the cochlea. And then next is the vestibular branch, which receives sensory stimulation from semicircular canals of the inner ear. Sensations of vertigo, which is dizziness, and your balance, equilibrium, and position of head in space.
Next we have glossopharyngeal. This is a motor and sensory nerve. The sensory tastes on the posterior tongue, and the motor function is swallowing.
Number 10 is the vagus nerve. The visceral branch carries sensory and motor information. The sensory carries taste information from the palate and epiglottis. Motor carries parasympathetic information to and from the heart, pulmonary system, esophagus, and the GI tract. Skeletal muscle branches carry motor information to the muscles of the larynx, pharynx, and upper esophagus. I couldn't say it right. These muscles are responsible for swallowing and speaking.
Next we have the accessory nerve, and it has two roots, the cranial nerve root and the spinal nerve root. The cranial nerve root controls elevation of the larynx during swallowing, whereas the spinal nerve root, it innervates the SCM, which is pictured right here, and innervates the upper traps. So the SCM does head rotation to contralateral side and head flexion and extension, and the traps help with the upper traps help with shoulder elevation and shoulder flexion above 90 degrees.
Lastly, we have the hypoglossal, and its function is tongue movement.
The olfactory pathway goes from the chemoreceptors in the nose to the inferior frontal lobes, to the olfactory bulb, to the olfactory cranial nerve, to the hippocampal formation in the temporal lobe.
The optic nerve goes from the rods and cones of the retina, sends visual information to the optic chiasm, but then goes to the optic tract, thalamus, superior cochlea of the midbrain, and occipital lobes for visual detection and interpretation.
The ocular motor nerve begins at the ocular motor nucleus and enters the cavernous sinus. It leaves cranial cavity via the superior orbital fissure, and there it divides into superior and inferior branches.
For trochlear, it originates from the trochlear nucleus in the posterior midbrain. It runs within the subarachnoid spaces and travels along cavernous sinus before entering the orbit of the eye.
The trigeminal is the largest cranial nerve. It originates from 3 sensory nuclei and 1 motor nucleus, which extends from the midbrain to the medulla. At the pons, the sensory nuclei combine to form the sensory root, while the motor nucleus continues on and creates a motor root.
The abducens arises from the abducens nucleus in the pons of the brainstem. It then enters the subarachnoid space and travels the Dorel's canal. The nerve leaves and travels the cavernous sinus and lastly enters the bony orbit.
For the facial nerve, this nerve comes from the pons. A motor and sensory branch travel through the internal acoustic meatus and exit into the facial canal. While in this canal, the two roots fuse to make the facial nerve.
Vestibular cochlear auditory runs from hair cells of the organ chordae to the vestibular nucleus in the brainstem. The vestibular branch runs from semicircular canals, utricules, to the vestibular nuclei of the brainstem.
The glossopharyngeal originates in the medulla oblongata of the brain and leaves the cranium via jugular foramen. Extracranial, it descends down the neck.
The vagus nerve arises from the medulla of the brainstem and exits the cranium via the jugular foramen. In the neck, it crosses over into carotid sheath and divides into two pathways at the base of the neck. It travels on through the thorax, then terminating in the abdomen.
The accessory nerve, the cranial component, arises from the lateral aspect of the medulla oblongata. It leaves the cranium through the jugular foramen, which briefly contacts the spinal part. The spinal component arises from C1 to C5 to C6, depending upon your source. It runs superiorly to enter the cranial cavity through foramen magnum, and it then goes to the jugular foramen.
Cranial nerve 12 originates from the hypoglossal nucleus in the medulla oblongata. The nerve exits the cranium through the hypoglossal canal. The hypoglossal nerve passes the mandible and enters onto the tongue.
Next, we're going to go into lesion symptoms. Starting with olfactory. If the lesion is unilateral, there's no symptoms because the opposite olfactory nerve kicks in and compensates. If the lesion is bilateral, the individual loses the ability to smell, which is also known as anosmia, which often occurs due to a head injury.
Next, we have the optic nerve, and their lesion symptoms are, if it's unilateral, it produces ipsilateral blindness, and if it's bilateral, it produces bilateral blindness.
For ocular motor, the lateral strabismus is a lesion symptom, and eyeball deviations outward because the medial rectus is lost and the lateral rectus is working unopposed. So this can cause diplopia, which is also known as double vision, and it can also cause nystagmus and ptosis, as we've also mentioned in class.
Next is the trochlear nerve, and its symptoms look like difficulty moving your eyeball down and lateral due to lost superior oblique muscle, vertical and medial strabismus, difficulty walking downstairs, vertical diplopia, and nystagmus.
For trigeminal, the lesion symptoms for sensory are ipsilateral loss of sensation to the head, face, and inner oral cavity. The trigeminal neuralgia occurs when half the face loses sensation. For motor, it causes weakness in chewing and deviation on the affected jaw side.
For abducens, lesion symptoms include eyeball turning inwards, double vision, and nystagmus.
For facial, it is decreased taste on the anterior tongue and decreased corneal reflexes.
Next is vestibular cochlear. The symptoms for auditory include deafness, and then vestibular, there's nystagmus, vertigo, decreased balance and protective responses, and changes in extensor tone.
For glossopharyngeal, the sensory lesion symptoms are taste sensation loss on the posterior tongue. For motor, it is loss of swallowing, loss of gag reflexes, and dysphagia.
For the vagus nerve, the visceral branch has transient tachycardia and dyspnea. For skeletal muscle branch, there is symptoms of hoarse voice, difficulty swallowing, and difficulty articulating words clearly and slurring words.
For the accessory nerve, for the cranial nerve root lesion, it's dysphagia secondary to decreased laryngeal elevation. Whereas the spinal nerve root, it is the weakness of the muscles that the trap and SEM, their functions are. So rotating the head to the contralateral side, flexing the head laterally and forward. Those are both part of the sternocleidomastoid, whereas the trap is weakness of shrugging the shoulder and weakness flexing the arm above 90 degrees.
Lastly, lesions for cranial nerve 12 are dysarthria ipsilateral deviation of the tongue, dysphagia, and ipsilateral atrophy and paralysis of the tongue.